All right. Welcome, everybody. Thank you so much for coming to our research series. I have to tell you that, well, most of you probably noticed that our last session for this series, this curriculum, is going to be in September. It's scheduled for September. We are currently working on, as recent as this morning, we had a meeting, the next iteration of the research curriculum. And we toyed around with lots of different things to do, but as of now, I can somewhat confidently say that tentatively, we will start back in January. And it's going to be, involve a lot of things. It's not going to be a repeat of this session. It's not going to be a step up. It's going to be a little bit of a mix. So it will be very practical. It will sort of follow a curriculum in the way that if you have a project, one session will build upon the next. However, if you don't have a project, or if you don't come to every session, you're not going to be lost in the subsequent session. So we really look forward to active participation in that. We're going to try and make it very practical for you all, and have our experts from across the institution, so Carilion, VTC, VTCRI, and Jefferson, all involved in facilitating the sessions. Okay, so we look forward to your participation. So today, you may have noticed on the schedule, Maddie Tinzer was going to present today's session. She had to be someplace else, but she has sent two wonderfully capable, and I think Ronix is going to do most of the presentation today, individuals in her place. Ronix Matakato and Dr. Yan Zhang are here today to share with us a little bit about the data we hear a lot about in these sessions. My biggest frustration is, how do I get my data? I can't get my data that I want. So they're going to help shed some light on how do we get our data and lots of other things, right? There you go. Thank you all.
Hi everybody, my name is Ronix Modukadu, and I am part of the Health Analytics Department, and my role is a research analyst, research reporting analyst. Our group does many things, the many stages of data collection, many stages of data analysis. Our groups will help you handle, and we have a lot of experience with that. So do not hesitate to contact us if you have any questions in general, or about the presentation that I'm about to give. So the objectives for this discussion, we are going to touch on the different types of data sources that you might want to extract your data from. We're going to talk about some of the limitations of those data sources. Limitations related to timing, workflow, completeness, and accuracy. We're also going to talk about the different ways that we can get this data. We can do it either via computer program, we can do it by manual chart view. We're going to talk about how we decide which is the best method. We probably might even use a mix of both methods. Of course, PHI is very important. You need to know how to be able to handle PHI for any of your data research. And then the next three objectives are in regard to requesting information from us, and how long it will take, and how changing your data request, once you look at your data, how changing the scope of your request is going to affect times. So the first data source we're going to talk about is Epic. It is the data source that you probably deal with on a daily basis, and in fact, it's the data source that I pull from my research reports. And I think to get an appreciation for Epic, we have to look at how things were prior to Epic. Pre-Epic, there were multiple EMRs. The Ambulatory Clinic had one type of EMR, the emergency ER had another type, OR had another type. You might even have other types of EMRs around different facilities. So these EMRs did not necessarily talk to each other. So you didn't really have a comprehensive view of the patient profile. Well, when Epic came around, what happened was we could now target a patient from the moment they first encountered Carilion to the different encounters they might have through different facilities in Carilion. So you can, for example, prior to Epic, you might have a person who had an antibiotic allergy in ambulatory clinic. That same day, they might have presented at the ER, and that ER physician might not have known that, just because the two EMRs did not really share data well. When Epic came around, you'll be able to see that instantly. So you can get a good profile of the entire timeline of your patient visit and patient healthcare. And when we look at the types, if you look at the number of clinics, we have 220 outpatient clinics, we have 7 hospitals, we service about 1 million Western Virginia patients. So when you look at all the possible types of data points we can extract from those, it's really a large size. And we can take things like a patient's demographics, patient's labs, their procedures, their vitals, diagnoses, so many things we have a large data set to work with. And when we have a large data set, we can do things like we can run comparison models. We might want to look at different age groups. We might want to look at different BMI groups. You might want to put historic trends to make predictive models. You might want to do things like reduce admission rates. So all these things can be done with a very large data set. I think if you want to capture something like, if your research targeted somebody who had high cholesterol for three continuous years, you could do that with our large data set. If you want to target, let's say, something that might not be so common, like multiple non-singleton pregnancies, you could do that with our data, just because it's a larger scope and a larger number of data points. So it's really one of the primary data sources that you can use. And now I'm going to talk about some of the other data sources that you might be comfortable with, but you might not have heard about also. This is national registries. Two ones I'm going to discuss are the National Trauma Registry and National Death Index. These national registries are not really controlled by us. So what you see in them is what you get. So you really have to understand what kind of data they contain. National Trauma Registry is, of course, related to trauma patients who have arrived at one of the trauma centers will hopefully have a record in the National Trauma Registry. One thing to know about the National Trauma Registry is that it is voluntary for trauma centers to report on them. So, send data to them. So there's 600 U.S. trauma centers that submit data to the National Trauma Registry. And the trauma, like I said, trauma registry contains characteristics of patients entering trauma care, and it will contain things like abbreviated injury scale, and some of the other data points that might be contained in the trauma registry or National Trauma Registry below over there. You might want to use the National Trauma Registry if, let's say, your trauma, your trauma profile of patients in your local trauma database is not, the count is not high enough. So you might actually resort to using the National Trauma Registry in those instances where you need to pad the numbers for your research analysis. The other thing is you might want to use other registries. Another one is the National Death Index. And this one you want to use if you want to determine whether a person in your study has died. Pretty important index to use. It is actually, and I got this off a website, it is actually one of the most uncontaminated registry of death records in the United States. It contains information such as death dates, death certificate numbers, cause of death, social security numbers, date of birth, race, sex, and it's actually everybody in that National Death Index will have a death certificate tied to them. Another good thing about the registry is you can pull death data from citizens, non-citizens, children, or adults. So it encompasses a wide range of patients. The thing is, in order to even begin requesting the records from extracts from National Registry, you would have to pay a fee. It is not free. So the good thing is, chances are at least your trauma department might already have a collection of extracts spanning a couple of years. If you don't have access, if they don't have the dates that you need, then you might have to make a separate request and pay the fee to extract that. The other thing is, a lot of times the way the extract looks when you get it in your hand, it's not really in a usable form. And you can see an example of that on the right. That is an example of the National Death Index Registry. That represents one patient. And when you look at it, it's not really useful information. So if you take a close look at it, things we have, this actually represents some kind of a death code, called the death code. And this actually represents the number of hits of a social security number. So when you look at it, this is what you get. You will need to contact us or work with somebody else in order to make it into a presentable Excel sheet. And this data can be really, really large depending on the span of years. So one of the current requests I have right now is working with the National Trauma Registry. And what it is, unfortunately, is when you receive this data, it's in a bunch of files. So you have patient birth date, demographics information, one file. You might have like abbreviated injury score, another file. You might have Glasgow coma scores, another file. Like all the relevant trauma data points are among these different files. So what you need us to do is actually tie these files together so you can get a streamlined view of your data points. And of course, you can tie the trauma registry and the death index with your EPIC records to get more value for your data. Any questions regarding that?
I do. On your National Death Index, you have older requests there. What is when you say older, what kind of, are we looking at a year or?
Sorry, I should have clarified that. I'm very sorry.
That's
when I
okay.
say current request and older request, what I mean to say is National Trauma Registry is a current request that I am working on. So if somebody had requested data from the National Trauma Registry very recently, and I'm still working on that. National Death Index is a prior request that I had worked on. So I just want to let you know that these are requests that we can work on. You can always contact us if you need help analyzing the data, if you need help actually building or merging the data.
And is there someone at Carillion, or are there several people at Carillion that have access to this, that have paid a fee by Carillion? Or do we have to do it individually? Do you know?
My guess is to save on monetary resources. If a department had already has an extract available to them, they'd be more than willing to share it out. Exactly to who might depend on what, if you belong to a department, they're more than willing to share out to you. If you belong to another department other than, let's say, trauma department, you might have to talk with the chair or get on board with some kind of an agreement. Has anyone actually seen data from the trauma registry or the death index, or worked with data from there? No?
I have a question too.
Sure.
For either of those databases, the national ones that you talked about, do either or both have access to pre-hospital records? So for example, the National Trauma Registry, most trauma patients are encountered by EMS first. Is that data in there? Many people will die pre-hospitally, and that's still the purview of the hospital through the medical director. Is that included in the National Death Index, do you know?
If they died, if they died and they have a death certificate, they should be included in the National Death Index.
Okay.
They have to have a death certificate to be included in there. So I think the answer is yes. And if you need more so I'm not a 100% expert on the registry itself and, you know, the history behind it, and, you know, where they're really moving forward with this registry. But these are, I believe they're either .org or .gov websites. And when you go to those websites, there are tons of information you can read, like pages and pages and pages worth of information. When I was translating the National Debt Index, so taking all these codes and translating them, I think I read through over 120 pages worth of documentation in order to translate those codes correctly. So there's tons of information online, and if you can't, you know, are you part of the trauma? Are you part of the trauma department? Because if you know, if another source would be them. You know, if you can talk to somebody who's currently holding that information, they might be able to give you more information.
So if we were to need some information, and since you all are the translators, if we were to ask you for this information, what's the time frame that we could get the translation out, like the people spreadsheet?
So the answer, it's kind of hard to say. It can take fairly short time to a fairly lengthy time, and actually depends. Well, when I first worked, so the first time I ever worked with National, I only got one request for National Debt Index, and the first time I worked with there, it took me, like I said, I had to read all the documentation. It took me, you know, a couple of weeks to be able to read through it and translate the data, and then data check the data. I gotta make sure the data that I translated is correct. So it took me weeks to do that. Now, if you gave it to me again, I think I might probably be able to do it in a much quicker. If somebody, you know, and I don't, you know, somebody else who might have more experience with me than me working on that index, they might be able to get it to you quicker. So it really depends, and also depends on the number of data points you might be requesting. If you're requesting 2 data points from the National Debt Index, then, you know, there's obviously less work to be done. One thing about National Debt Index is there's a fee, of course there's a fee to get the National Index, but there's an additional fee if you want to get causes of death. So it's actually kind of like 2 reports. There's a base fee for just the National Index, but then if you want cause of death, you have to pay a separate fee for that. Something to keep in mind. Any other questions about this? All right. Another thing to keep in mind are there's the National Registry available to you. There's also local department registries. The one that I'm very familiar with is the RMH's local trauma registry. I think that they are actually mandated. The trauma department here is mandated to actually have that trauma registry. And I think it depends on the kind of trauma level you are. Trauma central level you are. They upload their trauma registry to the NTR like the other 600 trauma centers. The one thing to keep in mind about this is it's free. So if you need to work on trauma information and you don't have the resources, or you know, you're unable to get an extract from National Trauma Registry, go to our local trauma database and request the access from there. And Dan Freeman is the one who works and manages that, and he's a great guy, and he will help you out. Other kinds of departmental registries are well, there's many other kinds, and one of those is diabetes. Another one is cardiology. Cardiology is really big on registries. I think just about any department can have, you know, their own kind of registry. In fact, there's so many registries out there that we don't even. There's registries out there that we don't even know exist, because it's managed by the department. So unless they let us know about it, we might not even know that they exist. So if you working on a project, it might be best for you to coordinate with the department and ask them if they have, you know, a registry that might be helpful to you. These local department registries, a lot of times the department themselves can extract data from them. They don't necessarily need our help to do it. Our help as in the TSG's help to do it. Maybe I didn't go over this quite well. The definition of a registry is It's a database, it's a storage of records with criteria assigned to it, and that hopefully gets updated regularly. So if I were looking at the diabetes registry, I would say to myself, okay, I want only patients who have, who have been diagnosed with diabetes, and let's say that I want to make sure that they're living patients, right? And let's say that I want to make sure that there are the most up-to-date contact information is on there, the most up-to-date encounter information. Let's say a urologist, you want to know the date of the last time you saw a urologist, date of last time you saw an ophthalmologist, podiatrist, the most recent lab values, creatine, bond lab values. All those things will be housed, hopefully, in that diabetes registry. So it's the one place you can go to get all the relevant information, hopefully, for your study. The one department can have many types of registries. For example, there can be 3 or 4 different types of diabetes registries housed in there. Some of them, if one of them pulls for only live patients, the other one might only pull for both live and dead patients. The reason for pulling only for live patients might be because they want to do clinical follow-up. They only care about live patients to follow up.
So these, I'm confused. These are registered. These are data from Epic. So is it just our patients, or is it?
These would be just our patients. Just
Okay.
Carillion.
So in other words, there is a registry of all our patients that have diabetes. That if we wanted to be able to look at records of patients with diabetes, that might be a place to
Well,
go.
we have to look really carefully at the criteria that they use to create that registry. If the criteria is I want all patients, it could be as simple as I want all patients currently living who have diabetes. That could be one registry. It could be a registry that that department pulls from. There might be another registry that says, that might have different criteria for diabetes. So just because it's a diabetes registry, just because it's a cardio registry, don't expect all the patient population to be in there. There are criteria rules that define these registries. And there's nothing.
Data points from different registries and combine them?
Sure, absolutely. If there is something like if both the registries contain, let's say, MRN, certainly you can join them together. Shouldn't be a problem. And you'd have to probably do an extract from one registry and extract from another, and then join them later on.
What data software are they using to store these registries?
Some of them are stored within Epic themselves, within the Epic hard-coded in there, stored in Epic tables. Others are stored, like the RMH trauma database, actually stored on an external access database. So I don't think there's any direct way for Epic to actually go in and extract the data. There's someone who'd actually have to sit there and do an extract in Excel and get presented to you. Then you'd have to do the groundwork to merge that in with the remainder of your Epic population.
How hard are they to set up?
You'd have to make a formal request to TSG, probably get some kind of a chair approval. It can take weeks, months, because then as these registries are getting designed to meet your criteria and your needs, there's a lot of metrics being run, making sure that data that you see is correct. So when you combine all these different processes that give you the final registry view, it can take a lengthy period of time.
Yeah, well, I found it takes a long period of time. You just wanted a report that listed all infants in the NICU that had phosphorus checked and was a low phosphorus. We got it 6 months later when we already had to make a decision for which we wanted the data for. I mean, it was useless then.
Oh, sorry. Yeah, but it can be a lengthy process at times. But the good thing is once it's there, if it's general enough, you can go ahead and use it if it's relevant to your study, you can go ahead and use it. And then it can continue to also be updated. So, let's say a new patient that meets the criteria of the registry rolls in a couple of weeks later, they will be added to the registry over time. So it can be a dynamic registry that continually updates itself.
To the point on timing, and I apologize if it's later in your talk and I'm just jumping ahead, but can you tell us how you triage the requests
Sure.
for the information? So is it a first come, first served, or how is it determined the queuing of the requests that come in?
Sure. It is never a first come, first serve.
Okay.
It is, and it's one of the later slides in here, but it generally is, we triage and say this, depending on what the deadline driver is. If the deadline driver is a presentation, funding-based deadline, we'll probably prioritize those higher than general requests that don't really have a definitive deadline. So it's never really first come, first serve.
Yeah, because it's very interesting, because I've got a request for analysis of data I've spent many, many hours collecting for QI, and I've been waiting over 2 years for it. And nobody's told me why.
Is this a
To me,
request-
about this time, wait time should start figuring in, and when does...
You should have gotten some, no one contacted you in between?
Well, I mean, I got some work done, but I'm at the point again where I'm not going to have the data when I need to make a decision, because...
Is this a request to the Health Analytics Department, or is it a request to TSG?
Health analytics.
Health Analytics, okay. Let me get your information after.
Well, I mean, it's being worked on. I just got a note from the statistician. But what I'm saying is that anytime I've asked, where does this fit in the priority? When can I expect to have this done? I'm not getting an answer other than we're working on it.
Got it. Okay. Yeah, I mean, some of these projects can take a lengthy period of time, and I think your time frame is definitely an outlier. Certainly, the more complex the request, the lengthy of time can take for us to actually give you results. Sorry for your wait. There are other external databases that exist. This is a state database. So we talked about putting an enterprise-wide database, national registries. Here's another database you can access statewide. You can use this to access claims data. And it's extremely important to know when you look at a database, look at the data in it, exactly what they're collecting. And here you can see that this database is collecting commercial payers, third-party administrative, self-funded, and Medicaid. So if you wanted to use this for Medicare or TRICARE data, this is not the place to go. So it's extremely important to know the type of data contained in your database. And here are some of the data points that are included in the Virginia All Payers Claim database. And I can imagine that this might not be free. Another reason, well, you can also use this to if you have a Carilion data subset, you can use your Carilion data and compare it against other Virginia state patients.
Donna,
Yes.
is there any place where it's listed on a database or on a website or something, all of the databases that you all have knowledge of that we might pull from or might be able to?
I don't think there's, if you went to the website, if I went to our website, I don't think there's something out there that just lists these databases. Because there's so many out there, right? There's like the department database that we're not aware of. But I don't think there's any one place you can go to see all different kinds of databases.
So if somebody were to contact you and say, hey, I have this idea, do you know where, like you would suggest some registries that you know of or databases?
So, certainly, if we feel that we cannot pull the data directly from Epic itself, certainly we would recommend databases that you can go to pull that information from. It might be other Carilion databases, it might be a National Trauma Registry, it might be other sources of data. So certainly we'll make recommendations so that you get the fullest, most valuable data set in your hands. Another place we can collect data for you from is the Enterprise Data Warehouse, and it contains claims information, for example, Medicare patient claims. And if you want to answer a question such as how many of my Medicare patients what a number of admissions for my Medicare patients? Well, you can look at the Carilion data set and get the Carilion admissions, but what if you want to look at other regional hospitals, other regional facilities? So you get a wider scope on your answer. So if you look at, because of the different, I think Aetna, Humana, Medicare, and other insurance companies populate the database. So you can get information, clean information that's outside of Carillion that those insurance companies might put in there. Any questions so far? All right, surveys. This is actually my favorite kind of data, surveys. It's really important. It's the most disregarded data, unfortunately, but I think it's extremely important because it contains data that is not really documented elsewhere. There's no real good place to document this data in Epic or in any kind of registry. And the power comes to the survey when you can tie survey data to Epic data. For example, if you wanted to look at the number, if you had a surgery resident and you gave him a survey and said which procedures are you most comfortable with, you find out that he's comfortable with doing hernia procedures, but not comfortable at all with doing appendix procedures. Well, you can look at the Epic database and see, all right, let me look at all the number of procedures that this guy did. You can find out that the reason why he's not comfortable with that procedure is because he did 1 or 2 of them. Right, and maybe the rest of procedures he had a chance to witness a lot. That's one way you can use survey data. Another way you can use it is for patient experiences. The patient himself might be anonymous, but if you can tie that experience to a certain time frame, then you can look and see what's happening in the department. Why did that patient, for example, why was that patient not satisfied with the care he was getting? Maybe the department was busy at that time. Maybe the number of staff resources at that time or that date or that stretch of time in his encounter was less than it should have been. So surveys are, they're pretty important, and a bad survey will almost always change the workflow. A good survey will always reassure you, and a bad one will always help you get better.
So what you're saying, let's say if you send out survey to certain patients that, depending on how that survey's set up, it can be linked to their medical record?
It can probably be not necessary to the record. If it's an anonymous survey, it can probably not be linked to the medical record itself, but you can certainly link it to a certain time or a certain date or a certain department. And when you do that, you can see how that patient's experience aligned with other patients in that department in that time frame. You can glean some good comparative data from that. I think nursing uses surveys quite a bit.
There's a question on the surgical resident procedures. How good is that data? Because when I walk in the room, they just say, what's your name if they don't know you. The person entering an Epic, just to say you were in the room, it doesn't say you actually participated in the procedure. Are you doing that by who wrote the procedure note? Because that doesn't mean they participated in the procedure either. They just watched. Or is it self-reported data?
But if a resident is witnessing surgery and is actually part of the surgery team, they would be recorded in there. And that brings up a good point. The way you record an Epic determines whether or not you can extract from it later. If you record something in notes, so you can write 6 paragraphs in notes, really descriptive, but we will not be able to data extract that. Data extraction can only occur on discrete data points. BMI, weight, ethnicity, discrete data points that you enter into a cell. If you enter it into notes, it is not extractable. And I've had situations where people were really good research projects, but the information had to be gleaned from the notes. And we had to they had medical students and other staff sit down, pour through these notes, spend hours and hours and hours trying to gather that one piece of information, go through multiple charts, and that could have easily have been recorded on a discrete field instead. But it was just the workflow process of that department to record in notes instead. So be very careful when you do that.
Do these registries have an ability to, while you're writing the note, say, oh, let me add this to the registry real quick? And have the user, as they're writing the note, say, well, let me add these fields in the registry, fill them out. Or is the registry something that's just running behind the scenes,
There's certain part, I don't think, I'm not 100% sure, but I think that what you enter in notes stays in notes, but in certain instances, what you enter into discrete fields can be extracted into notes. I don't think it really works vice versa.
You can extract from the smart forms or that they create and fill in the blanks, correct? If you use a smart form where
Yeah.
the physician or whomever
Right.
fills in the blanks,
Right.
then you guys can do data extraction from that,
From
from the
smart
smart
forms.
forms.
Templates.
I don't think
Templates.
Yeah.
Yes, you can.
Yeah.
Can you-
Central
okay.
line,
All right.
we're now collecting data on central line placements.
Okay.
Or the worksheets, and the flow sheets, things like that.
Lotion.
I myself have not worked with smart forms, so you guys are the experts, certainly experts
so
on that.
there's, so you can create them and they can, if they do a smart form and there's certain data points that you're looking for, if they all use, and when like the physicians in that area or whatever, if they want to do a registry, if they all use the smart form and enter the certain points in that they're looking for, then at some point after they've seen X amount of patients or whatever they're looking for, you guys can do an analysis of that information and provide it for them to use that data,
Okay.
from what I understand. It's an Epic. You have to have it built. You have to have that form built. They use them in some of the cardiology.
Yeah, I just found nobody in GI uses the smart forms except one provider.
Yeah, that's
Yeah,
the
yeah.
thing. You
Yeah,
gotta
it's not
get everybody on
common, yeah.
board to do it.
Yeah. It's not very commonly used, I don't think. Yeah, so we looked at some of the data sources you can go to for your data collection. And not all data sources are created equal, right? So there's definitely weaknesses in these data sources and other ones you might use. So we're going to look at some of those inherent weaknesses that you might encounter. Very, very important slide. This slide shows you different Epic rollouts. So you can see that Epic first rolled out Ambulatory Clinic in 2008, and then to RMH later in 2008. So if you look at Optime was not, Epic did not roll out to Optime until 2010. So if you want to collect ED patient information in 2008, for 2009, you certainly can, right? Because this is updated in 2008. So if you wanted to, however, tie ED admissions to, let's say, surgical records, like how many of the ED patients that came in, how many of them ended up requiring emergency surgeries? Well, you can see that Optime did not roll out until 2010. So if you're looking at 2009 ED data, then trying to get 2009 Optime data, it's not really a good idea. And if you attempt to pull populations prior to these dates, then you won't have complete information, or you might not have information at all. So for example, in Optime, this is the count that I actually did for surgery records. In 2008, there were 0 surgery records in Optime, or in Epic. In 2009, there was a little bit more, and for 2010, 11, 12, it stayed consistent. So why is that? Well, it doesn't mean that in 2008 there were no surgeries that happened. It's just that the Epic records were not updated at that time. Epic did not roll out to the Optime data model until later. And then you can see that rollout was in October 2010. If I look at 2009, I get some data, 2,500 surgery records. That's because before it had finally rolled out, it was probably being developed and surgical records weren't being imported. But if you wanted, but it's still an incomplete record. It doesn't contain all the records that you might be looking for. But then after the rollout, look what happened. After the rollout, we get, for the same month, right, November 2010, November 2011, November 2012, we get approximately the same surgical records, which is expected now. Right, after rollout, things become consistent. And here are some of the other rollout dates for, does everybody understand these terms like stork and Cardiant? Is that familiar to all of you? Stork is for the pregnancy data model, anesthesia, of course, anesthesia data model. cardiology, radiant model, radiant imaging, uptime operations, NRV is our other facility in Nuremberg, and CMC is RMH and ambulatory. Any questions about this? Because this is a really, really, really important slide. If anything, in this entire presentation, if you take away this. No questions? Okay, and of course, the data source is limited to the workflow process that populates it. So who records the data? Who actually populates the data? Is it your department or is it external? If it's your department, then you probably have more influence on controlling how the data is put in. If it's external, you might have little influence or no influence at all. Example, National Trauma Registry. You probably had no say in how in the data that's contained in there. What is the process that followed? If you understand if you understand the workflow process that went into populating this data, you really get a good insight into, or a good outlook of what this data contains and how to read it. So make sure you spend enough time, not just collecting data, but really understanding the data source itself and how it was populated. That'll give you awesome insight. Are there inconsistencies in the processes of populating this data? There can be many, of course, there's many inconsistencies, and one of them could be that just working in an ED environment doesn't allow you to populate on a regular, consistent basis, right? ED operation pressures might prevent you from doing that. You might get new personnel that might not just be trained on that very well. You might have the day shift doing workflow one way and night shift doing workflow another way. When I was in my previous workplace in West Virginia, the day crew would get trained really well. We'd have contractors come on and train the day crew. When shift turnover happened, the night shift needed training. We, who had been trained that day, would have to train the night crew. So you can imagine the difference in workflow that occurred between day and night shift. Have workflows changed over time? Well, when workflows are first implemented, people are really on board to go ahead and do everything correctly. 1 month later, not so much. 2 months later, not so much. A year down the road, probably people probably forgot about the workflow. So you got to see, you got to really look at maybe your department and see how the workflow changed over time. Maybe leadership vision had changed. So maybe one workflow process was determined to not work very well. So maybe leadership decided to drop that workflow, replace it with another one. Maybe just decided to update that workflow. So it's important to know, to understand the workflow over time and if it had changed. So there's a couple of things to keep in mind. Here's a good example, Code Blue documentation. It had originally been entered in flow sheets, but inconsistently by nurses. And then there was a better Epic integrated process that was supposed to fix that, but it still doesn't work very well. And there was a 5 to 6 month period in which both processes were used. Right? So how do you fix situations where the workflow process is inconsistent? Well, just limit the time period to when you think or know or feel that it had been documented correctly. Any questions? Completeness. This is another issue. How complete is your documentation? Well, it's sometimes hard to answer this, how complete it is, because maybe experience can tell you. And that's one we look at. If you're not sure, look at the data set you get and see if the pattern makes sense based on experience. If you're unsure, you can also consult with other people, the other experts in the field. You can also compare your data to the other data sources. So how does the National Trauma Registry look? How does that index registry look? How do these other registries look? How do the other external data sources look? Is your data, is the way your data looks, the trends in your data different from the trends in those data sets? So it's good to run, comparative models in these, if you have time, in these different data sources. Are there significant gaps that might bias your data? So just because you get, if if you ask for a immunization, if you want to see how if patients have been immunized, pediatric patients have been immunized, just because you get a result with 50 patients, just because you get 50 patients doesn't necessarily mean that only 50 patients have been immunized. Immunizations might not be recorded correctly. That's something you might need to be aware of. There might be gaps or holes that might lead you to one conclusion when that's actually a fallacy. Just make sure that you understand there might possibly be gaps in the database. Another thing is how critical the data points that may be. Just because you're missing data points doesn't mean you need to discard the data set. For example, someone recently asked me if I could, in the data set, can add a third field that looked at diagnosis codes. Well, that third field was just so that they can quickly target their patients. They still have to look to get a minimum number of patients to fit their study. So they had a patient list of like 500 patients in there, and maybe all of them did not have a diagnosis code in there, or a certain diagnosis code as patients. Well, this patient didn't care. I mean, this person didn't care. He just went through got the first 200 that fit diagnosis codes and discarded the rest of the data. So just see if those data points that are included are actually really critical to the data itself. You might be able to, another thing, you might be able to fill these gaps in data another way. There might be other alternate methods in which you can fill gaps in data. Another thing to look at is how, these data points, if you're missing data, does that data point affect the statistical results? And if it doesn't affect statistical results, maybe it's okay to have those data points missing or incomplete. Here's a good example. This is from an NIH publication, and it says that in ED databases, cause of injury code, certain joint injuries are frequently missing, and so are the mechanisms of injury, motor vehicle, fall, etc. Right? Frequently incomplete. So it's up to you to go ahead and, even though it's incomplete, there are instances of those data points out there. Collect them from different sources, and you might end up with the complete number of cases that you need for your study. Other examples: ethnicity, race, employer, history of disease. They might not all be completely filled out. All right, accuracy. How accurate? So the accuracy is not just that the data point has to be present, but is it reliable? One of the determinants of that is whether the data is discrete or whether it's free text. Free text has more room for error. Discrete, you're kind of limited to your avenues of error. Is the data source is it collected the same way each time? And is it collected by manual entry? Is it collected by automated procedures? Is it a mix of the same? So that's important to know. Are the collectors themselves consistent? So if I request 2 reports, and those 2 reports are done by different reporting analysts or different departments, are the people entering dates the same way? It's the same format. Is one person entering date, another person entering date time? How is the person accounting for nulls, for null values? Are they entering zeros on there? Are they putting a dash in there or just leaving a blank? Let me go back to that recording dates versus date times. That might seem insignificant, but when you start looking at definitions of arrival, did someone arrive on, what's the length of stay of a patient? So having a date time in there will really give you a more precise value and length of stay than just having dates in there. What's the definition of arrival? Does arrival mean arriving in the ED? Or does that mean being admitted into the room? Or does that mean being seen by the physician? So what exactly does presenting in the ED mean? So you have to be very careful about what the column definitions mean. And if just because you see discharge on a column doesn't mean that, you have to understand whether it means hospital discharge or ED discharge. So again, understand the definitions that go behind these column names. And for an example, on accuracy, NEDOC score. So NEDOC scores is a measure of overcrowding the ED. The formula calls for part of the formula is one of the variables is the number of ED beds. In 2016, January, this had increased in size, so if that was not updated in database or data source you're looking at, you'd probably be getting the wrong NEDOC score. Another example is ethnicity race. A lot of times, well, according to this publication, there are many instances where ethnicity race is determined by visual observation rather than actual data from the patient themselves, verbal data from the patient themselves, or written data. Any questions? This slide talks about manual and programmatic field extraction. So manual is when you go chart review and you go fishing for your data results because it's in notes field or it's in another location that might not be easily extractable automatically. Programming, so when we create code to go ahead and pull for that data. So which is faster? It kind of depends on the number of data points we have to pull, on the number of Epic screens you have to go through, the number of database tables we have to go through, whether the data point itself is discrete. Are we looking at the most recent data point? For example, do we have to look at, are you looking at the most, like someone went for surgery. Are you looking at the BMI most recent to surgery? Are you looking at the current BMI? So, the date time point of that data is important. And historical flags, if you're looking at diagnosis history, we have to look at every single table that contains diagnosis, see if that person has been diagnosed with that disease. Is this field straight field? Is this like BMI? Is it weight? Or is it something that's calculated like a NEDOC score? So, these are things to consider in deciding which method to use and which method is faster. Masking PHI. Some fields need to be masked PHI. We need to have PHI information masked. This is best done programmatically. So when you submit a request to us, we will give you, there's a data collection tool that goes with that request. And you go ahead and put all those data points that you need. And we will look through those data points and let you know if all of these can be gotten automatically, or it might be best to do some manual review on your side to extract those data points. If you have three data sets and those data sets are all on one Epic screen, it might take us 2 weeks to get that done programmatically. It might take you just 2 days if that record number is low enough. If it's only like 10 or 15 patients, where it would take us a much longer time to do it on the programmatic side. PHI information. Some of this PHI information always needs to be protected and handled carefully. My understanding of PHI since I came to Carillion has really evolved. PHI does not just mean name, it does not just mean social security number. It's any data point that can be combined to try and identify a patient. So even things like account numbers, insurance numbers, and ages over the age over greater than 90. All those things can can help identify a specific patient. PHI information, I think definition of it is any healthcare, payment, and demographic information used to uniquely identify a patient. If your research needs PHI information, you can certainly get a waiver to include it in there. If your research strong depends on, like if your study is based on geriatric population, so maybe you do need to see the number, patients over the age of patients if they're over the age of 90. But things like name are, I would almost always advise against it, and I can really see no recent example, at least in the reports that I requested, where where name was a required field that need to be included in a research data set. One interesting story, there's a colleague of mine who used to work in another facility in another state prior, and he told me that one of the data sets that he had to extract was name, and it was a name associated with some diagnosis codes, and they ended up extracting the name of an employee that worked in that same department. So it's almost always a good idea to eliminate names from the data list if possible. So some things you might also think. Of course, photographic images. The second to last one, unique numbers or codes including initials. With the year of your date, or birth date, that's not, that you'd be violating PHI. If you can, even taking the social security number, dividing by 16 to arrive at a unique number, right? Even that is considered PHI. Because you can, a person can figure out the algorithm you use and trace back what the actual data value was. And if you have any information, if you have any extra questions regarding this and want further insight, you can certainly contact us, and you can also contact the Research and Development Board and IRB Committee.
Ron,
Yes.
if somebody contacts your office, all of your services are free of charge, correct? All of it?
I think so. I believe so. I have never been, so I've been at my department for a year and a half. I have never been aware of an instance where we charge somebody for a request.
Unless, of course, you have to pay for one of the registries or something. That's just not associated with what you do.
Right. And I believe all our services are free, but I certainly my director would know more about that. But I've never encountered a situation where somebody had to pay for a request.
And how costly typically are those, like the National Death Registry? How costly is it to pull from those?
Not very. I think it's something like hundreds of dollars, like possibly like 800, 900 maybe, if you want to include the cause of death codes in there. So we're not talking about like $25,000 or anything too major. Which is why, if you know of a department that already extracted from there, maybe they'd be willing to share it with you. So, things take away from PHI. If you don't need it, don't collect it. If you want waiver forms, you can download it from Research and Development website. When you conducted research projects, if your research is not QA, QI, you'll be given a separate EPIC login. And make sure you do that login when you conduct your research. And this brings back one of the first questions we got was, how do you submit a request? You go to this website, and in there's a web form, and you can submit for either a general or research or QA request. And in the request, there's spaces in the request form for you to include procedure codes, diagnosis codes, lab codes, and please provide detailed information regarding the background of your study and detailed information regarding what those codes mean. Include the exclusion criteria, and this last part is extremely important. Please include the deadline for this report request and the deadline driver, so we are able to triage your request properly. So if your deadline driver is I have a presentation on at the end of the year, and another person is I have a manuscript publication deadline or funding deadline at the end of the week. It allows, we'd obviously try to take care of the funding request quicker than the other requests. So it really gives us good insight on how to properly triage your request. One thing to note, you do not need IRB approval to do feasibility counts. Feasibility counts are if you need to see how many patients, so if you talk to a statistician, they say you need 300 patients that fit this criteria for you to do your study. You can contact us and ask us, can you just give me a number of patients then can you tell me how many patients fit this criteria? Is it 300, is it more? And we'll be able to give you that information, just as a count, without actual data points, right? You're not asking for MR or anything, just asking to see, does that population exist in our database? And for that, you do not need IRB approval, you do not need to go to research board for that. You can just contact us and let us know, and that way you won't be wasting your time pursuing a study that might end up being dead end because that data does not exist. Turnaround times of requests. So the more information and the clearer the information is on your request, the better we're able to triage it. Triage takes place every single day, Monday through Friday. The people involved in triage are my director, the vice president, my manager. So people at the upper level are involved in triage. So generally speaking, the more complex the request is, the longer it will take for us to complete it. The more data points you have, or the more kinds of calculations that go into arriving at those data points, the longer the request itself will take. The more focused and more specific the request, the less time it takes. And of course, it's not first come, first served. And in fact, a changing request. So once you submit a request to us, midway through, especially if it's 3 weeks in and your request is still being worked on, you might suddenly want to modify the request. You might say, oh, by the way, I forgot to include this in because I just read an article that this data point is really important. Well, that we'll certainly add that data point in there for you, but just now it might take us a little bit longer to complete a request. Sometimes once you get the data in your hand, you say to yourself, wow, this looks absolutely great. If only I had this one extra data point in there, it would just make chart review easier, it would make analysis easier. Can you do that for me? Well, that would normally require a modification request, so a new ticket to be put in, and we'll certainly do that for you. We really try and not create obstacles in your path. So if you come back to me and say, I just, here are the diagnosis dates, I just want you to really, I have the admission dates here in the data set. I have the visit dates. Can you just tell me, put a flag, can you compare these two already existing things for me and maybe come up with the length of stay or some other calculation based on these two data points? I would normally not ask you to put in a new request for that. I could probably do it on the fly for about maybe 1 or 2 days. So we really try and not create obstacles in your path. So I think we're out of time. Any questions?
You can talk at all about cost. Is that a different department to do cost of procedures, cost of
when it comes to cost data, I believe that Lawson, or when you say cost, Lawson might be a good database to go to. We have billing, professional billing and hospital billing dedicated teams in our site, so there might be a good resource to go to also. But I think depending on what kind of cost you're talking about, cost of items, like you're talking cost of inventory supplies, that might be best derived from Lawson. If you're talking about cost of procedures, we have billing personnel that you can, billing report writers that you can work with, so you get that kind of information.
So I find it frustrating that retrospective projects that get their IRB, they want you to delete the data 2 years or a year after the project's completed. I feel like we spend all this time collecting this great data, nice access database, and then we have to destroy it in 2 years. What's the motivation behind that, and how could we change that to be more database friendly for the future projects that could be utilizing that exact same data?
Well, I think that, the motivation behind it is that we don't want all sorts of medical data just lying out there that aren't being used on a regular basis. So we can't just have data floating around and just held in place and not, used consistently. But if you think that that you need to use that data for a long ongoing project, you can always submit renewals to the IRB. So I think like every year or every couple of years, you can submit a renewal application, and the IRB will allow you to hold on to the data set a little bit longer.
It's yearly.
Is it yearly? Okay.
Yeah, yearly.
So have you looked at all that UVA's de-identified database that they've got? They've got a great de-identified database that grabs from a whole bunch of different data resources. You don't need a lot of access. you know, you don't need a lot of privileges to get access to run quick searches on it. It's faster because it's on a different server or something. Has there ever been any talk on like, let's look and see what they're doing and see if we can replicate it here?
If they have, I've not been to those talks. I'm sure some entity currently has been involved in those talks, but I'm not aware of them. But we do have Virginia University, Virginia Tech collaborators requesting data from us. So I don't know so much about us requesting from them, but they definitely do request from us. Okay, thank you, everybody.
Thank you.
If you have any more questions, please feel free to come talk to me.